Good afternoon, and welcome everyone to today's webinar on Medicare Advantage payment and opportunities for cost containment. This webinar is jointly hosted by the Center for Advancing Health Policy Through Research, known as CAHPR, at the Brown University School of Public Health and the Georgetown University Center on Health Insurance Reforms. I am Andy Ryan, the director of CAHPR. CAHPR's mission is to generate the highest quality evidence about the forces that shape affordability, access, and value in U.S. healthcare, and to translate this evidence towards policy change. This work blends health policy, economic, and legal expertise to assess how emerging evidence can inform policy. Our work focuses largely on the supply side of healthcare, the intersection of payment, markets, and delivery. This includes a robust portfolio of work on emerging issues in the Medicare Advantage program. Recent research from CAHPR has examined important questions on how the structure and incentives in Medicare Advantage affect program outcomes. This includes studies on the impact of risk adjustment in Medicare Advantage, quality bonuses, favorable selection, the quartile payment system, and vertical integration, among other topics. Through this evidence, our work is sought to identify both the regulatory and statutory levers to improve the MA program. I'm excited for today's discussion, which will highlight much of CAHPR's work in Medicare Advantage, and look forward to our work with Georgetown and the feedback from the audience on these critical topics. With that, I pass things over to Carrie, who will be moderating this discussion.
I'm Carrie Graham. I'm the Executive Director of the Medicare Policy Initiative at Georgetown University. We are a fairly new initiative, almost a year old, within Georgetown University's McCourt School of Public Policy. We are affiliated with the Center on Health Insurance Reforms. The Center on Health Insurance Reforms has been around for a while. Lots of people know it as CHIR. They focus more on commercial insurance and ACA policy analysis. We focus on Medicare and Medicare Advantage. And our mission is to really look at what is working and what is not working in the Medicare Advantage program, and really to take an honest look about how to improve coverage, reduce costs, and provide meaningful choices for beneficiaries. To do that, we use a combination of approaches, including research and translating others' research, like Brown's research on Medicare Advantage. We do policy analysis. We publish issue briefs and blogs, so we'd love to see you on our website and mailing list. We also provide technical assistance, and you'll meet Neil, who is the head of our technical assistance practice. We provide confidential technical assistance to congressional staff and to the administration. And finally, we host expert convenings to bring the smart people together to discuss issues to improve the Medicare Advantage program. So I wanted to introduce my colleagues who will be on this panel. We will start with some speakers who will give you a bit of a background on how Medicare Advantage is paid, and then discuss some opportunities for cost containment and for improving the program. So from Medicare Policy Initiative, we will have Neil Patel, who is our Director of Health Policy and who runs our technical assistance practice. He comes to Georgetown from the CMS Office of Legislation. And I will also introduce Rachel Schmidt, who is a research professor in our little shop, and she comes to us as a former MedPAC and CBO staffer. So with that, just a little housekeeping. We will have a few speakers talking about different topics, and we want to hear your questions. So if you have questions, please look below. There's a little Q&A button at the bottom of your screen, and feel free to type any question that you have for the speakers into that box. If it's a simple question that just needs a real simple answer, we will. Not that Medicare Advantage is always simple, but if it is a simple question, someone could just answer it right in that box. Or after our speakers conclude their talks, we will have a section at the end to answer questions. So I am going to now hand it off to our first speaker, Hayden Brookley.
Thanks to everybody for joining us today. I'm going to speak just for a few minutes, giving a quick overview of MA, the Medicare Advantage program, introduce a few key elements of benchmarking and MA payment, which I think will tee up our discussion for the hour. Advance the slide, please. So as most folks are probably familiar on this call, Medicare Advantage is Medicare's private version of the Medicare benefit as contrasted with traditional fee-for-service Medicare. Essentially, private insurance companies administer, which are formerly known as Medicare Advantage Organization or MAOs, administer the Medicare benefit through this option. MAOs receive capitated payments on a per patient per month basis and they can, with that, design the Medicare benefit and offer it to Medicare patients who have the opportunity to either select into Medicare Advantage or go with traditional fee-for-service Medicare. Fee-for-service Medicare, a couple kind of core features, generally known for having its standardized benefit, so standardized premiums, copays, coinsurance, deductibles. Also, traditional Medicare has an open network, so any traditional Medicare patient can see any provider, physician that accepts Medicare. MA is contrasted with traditional Medicare in a few important ways here. MA plans have wide latitude to actually adjust the benefit design, so to adjust the plan, different premiums or copays. They also can devise networks, so can negotiate with providers to have them either in or out of the network when they offer their plans to Medicare beneficiaries. They also can use a couple different tools to manage utilization, most prominently using prior authorization, again, as a lever to try to manage overall utilization of Medicare benefits. As this slide here shows, the MA program has increased significantly in recent years, actually doubling in the last decade, as we see here from MedPAC. As of 2024, there were north of 33 million Medicare patients in Medicare Advantage, which constitutes over half, so 54% of total enrollment. And the MA program, Medicare spent upwards of $480 billion to finance the MA program. Next slide, please. So we're here to talk a little bit about opportunities for cost containment. So it's worth noting that there's emerging literature, emerging research showing that the Medicare Advantage program is significantly overpaid relative to fee-for-service. So comparing like beneficiaries in MA and TM, researchers, including MedPAC here, are finding that the MA program, Medicare pays significantly more for that comparative beneficiary. As we see here, the 2020 MedPAC estimates in 2025 that MA will pay $84 billion more in payments relative to fee-for-service, or that's good for about 20% more on a per beneficiary basis. Again, if we're trying to compare like beneficiaries. There are a number of different drivers that drive this estimated overspending. The two that MedPAC emphasizes here are probably the biggest drivers, and those are the risk adjustment system, which we'll have much more to say about in this webinar, as well as selection issues, favorable selection into Medicare Advantage. There are some others that other researchers have looked at, but the two main drivers and where we're going to focus today is on risk adjustment in particular. Next slide. So a quick overview here of the mechanics of Medicare payment policy and how Medicare payments are constructed. Subsequent speakers are going to get into a little bit of the statutory scheme of Medicare Advantage as we think about ways to potentially find savings in the program. Medicare Advantage delegates significant authority to CMS and Medicare to adjust payments, make them more or less generous to plans. But like most legislation, a lot of the Medicare payment policy and benchmarking is codified in statute. So as we'll see when we talk about policy levers, some of the tools to address overpayments would need to go through Congress. I also want to credit the Commonwealth Fund for this wonderful image here as part of their MA primer. And then just talk just briefly here about the main aspects of MA payment policy. So as I mentioned before, MA plans receive a monthly capitated payment from CMS to administer the benefit. This starts with CMS devising a benchmark, which is based on county level fee-for-service spending. Yep, stay on there, thanks. So the benchmark is derived from county fee-for-service spending and is actually the maximum amount that that Medicare would pay in MA plan. Now, to actually establish what CMS will pay an MA plan, plans actually bid relative to the benchmark. So plans will submit a bid. Most of them will bid below the benchmark, the overwhelming majority, and the plan will be paid the bid amount plus a rebate, and the rebate is a portion of the difference between the bid and the benchmark. And there are a couple other important factors here that dictate total payment. So the payment for plans are rated on their quality performance. So they're given a star rating on the basis of 1 to 5 stars. Good performance on star ratings, particularly a 4-star rating for a plan, will increase the overall benchmark, typically by 5%. And it will also, again, if the 4-star threshold is met, it will also adjust the rebate that the plan receives. So we discussed earlier, the MA plan will receive a portion of that discrepancy between the bid and the benchmark. Better performance on quality will increase that portion that the plan receives. The last factor that really plays into the MA payments to plans is risk adjustment. And this is Medicare's attempt to pay MA plans on the basis of the disease or perceived disease burden of the population that the MA plans are providing the benefit to. The payment that's adjusted is the plan bid plus the rebate. So the total amount that's actually paid from CMS to the plans is adjusted on the basis of this risk adjustment metric. And with that, I'll hand it over to David to say a lot more about risk adjustment.
Thank you, Hayden, and it's great that so many of you could join us today. My name is David Myers. I am an associate professor of health services policy and practice at the Brown University School of Public Health and the associate director of CAHPR. And I'm really excited today to talk a little bit about the basics of how risk adjustment works in Medicare Advantage and where some of the problems are that us and others have sort of identified before I'll hand it over to our colleagues at Georgetown to talk about some of the solutions and ways to tackle these issues moving forward. Next slide, please. So I think as Hayden teed up here, it's really important to note that risk adjustment is actually a really important feature of the program. If MA plans are going to be paid on a capitated basis, so you have a set amount of money you're getting for a year and taking care of patients, it is really essential for this system to work well that plans are paid more for taking care of patients that are going to utilize more services and have greater healthcare needs. And so while we're about to talk about a lot of the challenges with risk adjustment, I think it's really important to just sort of foreground that this is an important part of the system. But I think where a lot of our concerns come from is whether this is working well in its sort of current iteration. So the current way that risk adjustment works is through a system called the hierarchical condition categories, or HCC models. What CMS basically does is it trains this model on traditional Medicare spending and identifies these are the chronic conditions that are coded in traditional Medicare claims that seem to be related to greater spending down the road for that patient in sort of a subsequent year. They train this model in traditional Medicare, and then they apply it to Medicare Advantage. So what happens is in several of the encounter data sources, so when somebody sees a doctor, when somebody goes to the hospital, diagnosis codes are recorded. And those diagnosis codes are then categorized into hierarchical condition categories. And each of these conditions has a different weight to it. So some conditions have a higher weight, which means that it might be a more expensive condition to take care of, whereas other conditions have a lower weight and some conditions have no weights at all. In addition to sort of this initial weighting, there's additional adjustments in this model for patients who are dually eligible, get a pretty large and pretty sizable payment boost because there's greater needs among those communities. And there's other adjustments for people who are receiving long-term care or who are new enrollees in a plan in a given year. These codes are captured in the Medicare Advantage encounter data, which is sort of a newer shift. Previously, it was also reported through a separate system that was reported by plans. So while, this is an important system, where a lot of the concern comes from is that a lot of research has sort of highlighted that there might be excess coding on the Medicare Advantage side that's leading to distortions in payments between the two halves of the Medicare program. Next slide, please. So what are some of these challenges? So I think it's first important, again, to foreground that when we see differences in coding between MA and TM, not all of these differences in coding are necessarily false. It could be the case that beneficiaries enrolled in MA could be sicker sometimes than beneficiaries enrolled in TM. And it's also worth noting that TM, there aren't the same incentives to code because payment isn't usually set around these things, whereas MA plans do have a strong incentive to code. But we do see really big differences in coding between these two programs, and it's very difficult to sort of understand this, but there's been a lot of research over the past few years to try and dig into it. And a lot of this comes from the fact that there aren't many good gold standards to sort of compare utilization to and to compare sort of how sick one person is to how sick somebody else is, but a lot of research has started to tackle this. Next slide, please. So this is work from MedPAC, and I think MedPAC has been sort of on the foreground of thinking through a lot of these issues. And this is through this algorithm they use called the DESI method of sort of capturing coding intensity. And what they measure is that in 2025, coding intensity, after accounting for differences in demographic characteristics, appears to be about 16% higher in the MA program relative to what the coding intensity looks like in traditional Medicare program. And as they show here, this translates to about 40 billion in additional payment a year, and it's sort of gone up over time, the amount of additional spending that's taking place here, both as sort of this coding differences have gotten larger and also as more people have enrolled in the Medicare Advantage program. So there's been a lot of work to try and understand, other differences in coding that's going on. And we do see over and over again in the research that when people tend to enroll in MA, we see large increases in the coding that those patients receive. So next slide, please. So this is from a study from a number of years ago from some colleagues that essentially they followed beneficiaries after they were enrolled in traditional Medicare or after they were enrolled in commercial insurance, and then followed them into their enrollment in Medicare Advantage. And we see that once somebody enrolls in MA, they start to accumulate codes at much higher rates than people who are enrolled in traditional Medicare. This could be because they're a lot sicker, but when we sort of have different control groups and follow people across the two different programs, that doesn't always seem to be the case. Next slide, please. So this is from some work that our group published earlier this year, where we compared beneficiaries who had similar functional impairments and similar sort of health challenges to each other. And we find that no matter where across the distribution of how sick somebody might be, we see that the coding tends to be much higher in Medicare Advantage, that roughly a 10% higher coding we found in this study, which was focused on sort of a subset of the Medicare population. And so even when we do have these sources that are able to account for some of the differences in health status, we see at the same level of how sick somebody is, coding is higher in Medicare Advantage than traditional Medicare. Next slide. So what are some of the things that are going into these differences in coding? So there are different incentives between these programs, as I mentioned before, although I will caveat that it's not like there's no incentive for coding in traditional Medicare. ACO models, for example, some of them have incentive for coding. Hospitals do have some incentives for coding for risk-adjusted quality measures. So there's not no coding incentive in traditional Medicare, but it is, granted, not as strong as that incentive in Medicare Advantage. So MA plans actually have a wide number of tools that research that we've done and others have done that have sort of pointed to where these differences in coding tend to come from. So one of them is chart reviews, where basically MA plans can submit additional records after a visit occurs into sort of the encounter data that captures more diagnosis coding. They can conduct health risk assessments, so they can send people to providers to a beneficiary's home to conduct this health risk assessment to collect information that's often used for sort of coding intensity. And then there's been a lot of newer developments in the space that the research is a little bit earlier on, but where there has been some early concern, in particular around issues in vertical integration. So we know MA plans are starting to integrate to a greater degree with provider organizations, either through direct ownership of provider organizations or through sort of exclusive aligned partnerships with these firms. And we're starting to see some early evidence that these types of vertical alignments are associated with much higher coding intensity. And also it's been reported that plans engage in risk-based contracting with providers. And so if provider organizations are able to deliver more codes to the plan, it sort of leads to higher payments for that provider organization, furthering these incentives. Next slide, please. So work by ourselves and by others have found that chart reviews are one of the major drivers of this coding intensity over time. This is some work from a colleague from a couple years ago that sort of charted these chart reviews over time. And sort of the impact of the coding that comes from the chart reviews has increased substantially. And estimates of how much these chart reviews contribute to additional spending in the MA program range from $8 to $12 billion a year in what it contributes to in sort of excess coding. And these chart reviews can either be linked to actual sites of care and visits that patients received, but it can also just be sort of floating chart reviews where a plan submits additional codes that maybe a provider didn't capture, but that gets added to a patient's record and then gets used for reimbursement practices. Next slide. So a second area that I already mentioned as well are these health risk assessments. So we find a great deal of variation. This is from some work that we did earlier this year. And we find that different insurers use these health risk assessments at wildly different rates from one another, and that these health risk assessments can be associated with 15% increases in some cases in the coding that's captured for a given beneficiary. Again, sometimes these health risk assessments, if it is actually capturing a code that is relevant for a patient's care, the plan now knows this person has a chronic condition, can then connect that person to sort of further care use. That could be a good thing. But there's been a lot of concern that a lot of this capture is of additional diagnosis codes, but it doesn't actually really translate into any more care that the patient's receiving. Next slide, please. Some of you might have seen the Wall Street Journal has done some really excellent reporting on this over the last year, where they actually looked in the data at people who were receiving codes from health risk assessments and chart reviews that only came from plans, and looking at codes that were actually captured by doctors in the course of care delivery. And what they find is that if a diagnosis code of a chronic condition only showed up from what a plan's reporting and didn't show up from what the doctor was actually reporting, then there was a huge gap in whether somebody actually received treatment for that condition. And they found very big gaps for HIV and Parkinson's disease, but also for more common conditions like atrial fibrillation and diabetes conditions, that when a plan captures these codes from a health risk assessment or a chart review, it is less likely to actually translate into any further care that the patient receives, as opposed to other codes captured by doctors. And this raises some concern of whether these codes are things that actually should be captured and should be leading to additional reimbursements for these plans. And I think that that's what a lot of these issues come down to, is much of the time patients might have these chronic conditions. It's not that these codes are being sort of completely generated out of nowhere. But if the patient isn't actually seeking treatment or in need of any treatment for these chronic conditions, then it raises questions about whether this excess coding should be used for reimbursement purposes from plans. Next slide, please. And so there have been some changes that have taken place over time to sort of get into this, and I'll let Neil sort of take it away with talking about some of these changes. But CMS has tried to address this through sort of changes to the risk adjustment model. But there are a lot of challenges that do remain. Two of them being this vertical integration point that I raised earlier, but then also there's a lot of variation across different plans in their capabilities and sort of the different levels of coding that they have, which raises a lot of concern about how anti-competitive this might be, and sort of getting in the way of sort of smaller plans being able to compete with bigger plans that engage in this activity much more often. So I'll stop there for now, and I'll hand it over to Neil, who can talk a little bit more about what some of the solutions to some of these challenges might be.
Thank you so much, David. Yeah, so my name is Neil Patil. I'm the Senior Fellow and Policy Director here at Georgetown's Medicare Policy Initiative. And I'll be talking a little bit today about how the federal government what the federal government currently does now to tackle some of the issues that David raised around upcoding and overpayment, and also what are some opportunities out there for future legislative or regulatory reforms. Next slide, please. So as David mentioned, risk scores are about 16% higher for enrollees in MA compared to traditional Medicare, according to MedPAC, and also that CMS has implemented some changes to their risk adjustment model beginning in 2024 and fully phased in for 2026, which included removing certain diagnoses from payment where CMS found evidence of discretionary coding. But there's also other things the federal government does. So the statute requires CMS to reduce risk scores by a minimum of 5.9%. And since 2018, CMS has reduced the MA risk score by 5.9%. While CMS has the authority to actually increase that coding intensity adjustment, thus far has not exercised that. Outside of what CMS does, actually, the False Claims Act requires that any person or entity, including an MA plan, who knowingly submits or causes to submit false claims to the government is liable for penalties. And the Department of Justice has filed numerous complaints regarding overpayment with respect to fraudulent coding. Including one recently for a major Medicare Advantage organization where they alleged the MAO had retained about $2.1 billion in overpayments. But our focus here is going to be on the risk adjustment data validation or RADV audits. So this is CMS's primary way to address overpayments to Medicare Advantage organizations. So under this process, CMS selects a sample of Medicare Advantage contracts and enrollees to audit, where they're going to review the encounter data that that Medicare Advantage organizations submit to CMS for payment. And they're going to check that against the enrollee's medical records. So this is conducted at the contract level. And based on these findings from these audits, CMS will recalculate risk adjustment payments and potentially require Medicare Advantage organizations to pay the federal government back or recoup funds from these Medicare Advantage organizations. So particularly what they're looking at here is they're trying to confirm whether a diagnosis that was submitted by an MAO for risk adjustment was actually supported in the enrollee's medical record. And I just wanted to point out here that CMS's 2022 RADV audits found that about 21% of insurers had coding errors, and that could be anything from a missing diagnosis to missing documentation. Next slide, please. So while the RADV audits are CMS's primary method for collecting and recouping overpayments, there are certain challenges and limitations with this. So the first piece is that CMS is conducting audits of samples of contracts. So while there's about 700 Medicare Advantage organization contracts, CMS is really conducting audits of about 30 of those each year. So we're talking about less than 5% of these contracts. Also, these RADV audits are not looking at whether enrollees are receiving care for the diagnoses reported. It's really just to check that the diagnoses that are reported in the encounter data match what's in the enrollee's medical record. Now, CMS has taken some steps to expand these RADV audits, beginning with payment year 2018. So this was part of their 2023 RADV final rule, which is linked here. But essentially, what the rule does is it allows CMS to extrapolate the RADV findings. So what this means is CMS is really able to kind of expand and take the results of these audits and extend them across the entire contract. So in the past, CMS had only actually looked at the sample of enrollees from the sample of contracts and calculated overpayments, but now they're going to have the authority to extrapolate that across the contract. Now, a lot of policymakers and individuals out there have talked about, actually, why doesn't CMS just conduct audits of all contracts or a larger sample? Well, these RADV audits are actually quite expensive. Annual expenditures just to conduct these audits are approximately $50 million per year. And there have been legal challenges related to these audits. So primarily coming from Medicare Advantage organizations have raised certain legal challenges focused on audit sampling, requirements around actuarial equivalence between traditional Medicare and MA, including some pointing out that there's evidence that that traditional Medicare undercodes compared to Medicare Advantage, as opposed to Medicare Advantage overcoding, creating issues with actuarial equivalence. And also, as I talked about this extrapolation that the RADV final rule will be doing, this expansion methodology, there's been a lot of uncertainty since CMS did not actually specify the methodology that they would be employing with respect to this extrapolation. Next slide, please. So, we just talked a little bit about what CMS currently does and some of the limitations there. But now we're going to talk about the potential, legislative and regulatory pathways here. So one of the potential solutions that has been raised by a lot of different organizations out there, as well as members of Congress and various policymakers, is actually just excluding certain diagnoses from risk adjustment itself. So as David mentioned, there's been a lot of increased coding as a result of chart reviews and HRAs, which might not be actually leading to care for these enrollees. So one of the potential policy solutions is actually excluding certain diagnoses, and that could be diagnoses derived from chart reviews and HRAs, which is part of the No Upcode Act sponsored by Senators Cassidy and Merkley. It's also a MedPAC recommendation. Our own Brown University actually has provided another potential option, excluding certain diagnoses and using a combination of survey data with diagnoses to actually determine Medicare Advantage payments. And others out there, such as the UC San Diego, has proposed excluding the most intensely coded diagnoses from the MA payment model. And I believe that their proposal was to exclude 10 diagnoses groups from the MA payment model, those being the diagnoses that are most highly coded. But, changes like this and sort of when you're looking at excluding diagnoses from risk adjustment, one of the things that we've talked about a little bit is that plans can be quite nimble, and it could be the case that changes like this could increase incentives to code for other diagnoses that are not being excluded. So we'll also talk a little bit here about some of the potential solutions with respect to coding intensity. So as I mentioned, there's a 5.9% coding intensity adjustment that's statutorily required, and that's a minimum adjustment. So CMS could increase the coding intensity, but since 2018, they've just been applying that minimum coding intensity adjustment. But others out there have talked about either increasing or using different methodologies for coding intensity adjustments. CBO has actually proposed increasing the minimum coding intensity adjustment by 8% or even 20%. 8%, they had they projected that that would result in about over $150 billion in savings over a 10-year window, and increasing that minimum to 20% could save about $1 trillion over 10 years. But there's also been discussion of not employing a one-size-fits-all coding intensity adjustment. Really, what we've and what some of the research has shown is that coding intensity actually varies quite a bit by plans. It's typically larger Medicare Advantage organizations that where that might have the resources to do things like HRAs and chart review records that actually tend to exhibit a higher coding intensity. So one of the proposals out there has been a tiered coding intensity adjustment where CMS could actually apply different coding intensity adjustment levels based on the size of the contract or the level that the contract has been historically coding or by other methods. Other ideas out there include variable coding intensity adjustments, such as the demographic estimate of coding intensity or DESI model. That really what that tends to do is actually control for demographics. So Medicare Advantage members that are actually, no healthier, no sicker than similar fee-for-service beneficiaries, it would actually control for their demographics. And when you do that, MedPAC has actually replicated that model and found that it produced coding intensity estimates of, I believe it was around 13% in 2019, and most recently in 2024, that increased to about 20%. Next slide, please. So there have been various proposals out there related to reforming RADV audits. One of them that was actually included in the fiscal year 2024 president's budget, so that would be the former administration, was actually including targeted risk adjustment prepayment review. So basically, before CMS makes risk adjusted payments, CMS would be reviewing the encounter data that plans are submitting and actually conducting a RADV, almost like a RADV audit on the front end. Now, this is part of the president's budget proposal, and it's very vague as to exactly how this would work and how this would really interact with RADV. But you can kind of think of this as a RADV audit on the front end, a prepayment review. The OIG, the Office of Inspector General, has suggested that CMS conduct audits to specifically validate all diagnoses reported on HRAs and chart reviews. This, of course, going back again to another mechanism to tackle increased coding through these tools and resources. And finally, various groups, including Paragon Institute, have suggested that CMS could audit more contracts and also add penalties for overpayments. So like I mentioned, following a RADV audit, the Medicare Advantage organizations may be required to repay. CMS might be recouping overpayments, but there's no additional penalties on top of that. And then finally, we want to talk a little bit about increasing transparency. One of the issues that MedPAC, as well as other organizations, have raised is that there's still not a lot of completeness and accuracy of MA encounter data. And policymakers could consider creating incentives to increase the completeness and accuracy of MA encounter data. And as that flows through the risk adjustment model, policymakers, have envisioned that could result in improved accuracy for payments. Ideas about creating of these incentives vary, but it could be establishing a payment withhold policy until accurate and complete data is submitted, or creating metrics to measure plan performance related to the completeness and accuracy of MA encounter data. And finally, increasing transparency of supplemental benefits. So as Hayden discussed, MA plans can offer benefits that traditional Medicare does not cover. Those are supplemental benefits, and most commonly those are dental, vision, hearing, but there's still not a lot of transparency and information out there about the cost and the utilization of these benefits. Increasing that transparency, requiring additional reporting, could further improve the accuracy of Medicare Advantage payments. And lastly, before I hand it over to my colleague, Rachel Schmidt, I wanted to mention that you can visit the Medicare Policy Initiatives compendium for more MA reform options. We have included a compendium of a lot. Rachel can tell you how many of policy options within various buckets, including certain options out there related to MA reform. And with that, I will pass it over to Rachel.
Thanks so much, Neil. So I'm going to be touching on some things that Hayden described in some of the initial slides. And I think perhaps an underappreciated aspect of Medicare Advantage relates to the fact that plan payments are tied to how CMS evaluates quality through the star ratings. And those star ratings can have large financial consequences for federal program spending, for plan payments, and for beneficiaries in terms of supplemental benefits that they sometimes receive through the Medicare Advantage plans. Next slide, please. So over the next few slides, I'm going to give you at least a simplified overview of how the star ratings are built and used, and issues that have been raised with them, and proposals for reform. And in terms of how they're built, each year CMS evaluates data about Medicare Advantage contracts and assigns an overall rating of 1 to 5 stars for excellent performance. These are built from clinical, administrative, and member survey data that are trying to capture things such as access to care, the provision of preventive care, the management of chronic diseases, quality of health plan services, and enrollee satisfaction. It's based on a basket of about 40 measures, 40 used currently for most Medicare Advantage prescription drug plans, and they're grouped into different ways for different purposes. But for purposes of combining them into one overall star rating, I've kind of laid out on this slide the fact that the measures fall into 6 categories, and each measure is assigned a weight. So for example, for 2025, patient experience measures are weighted about 4 times more than process measures. Stars come with a lag. They reflect the plan's previous performance. So for example, the 2025 star measures were released in the fall of 2024 by CMS, and they were based on clinical data that were measured in 2023. And the 2025 stars will be used for 2026 plan payments. Each measure, each of the component measures, is assigned a star rating, and the overall star rating is basically a weighted average using the weights in this shown here, rounded to half stars. Now, this is a very simplified overview. There's lots more complexity to this. There are things that CMS does behind the scenes related to data reliability and where to set cut points and dealing with outliers and other sorts of adjustments to these star ratings. Next slide, please. So how are these ratings being used? They're used in 2 main ways: to inform beneficiaries about the quality of Medicare Advantage plans, and also to provide financial incentives for plans to deliver high quality care. So the Medicare Plan Finder, medicare.gov, is where one can observe these star ratings for the current year. And the intent there is to help beneficiaries choose among the plans, choose among their options, and look for higher quality plans. Beneficiaries also get additional opportunities to enroll or to switch plans at times of the year when most beneficiaries can't do that. For example, to enroll in a 5-star plan or to leave a plan that has consistently low ratings. Plans that have consistently low ratings can be subject to marketing restrictions and even potential termination of a contract with CMS. And of course, stars are a very important component of the MA payment system, and we're going to focus on that more next. Next slide, please. So in terms of MA payment, they're used 2 ways, as Hayden laid out. They're used to set quality bonus payments, as well as to set the size of rebates. So if you remember back to Hayden's slides, that CMS compares plans' benchmarks to their bids for what they think the revenue that is required for providing Part A and Part B benefits, including their administrative costs and profits. So plans that get 4 or more stars get a quality bonus, and that means that their benchmark is raised by 5% or double that in certain counties. Now, this is not a budget neutral system, unlike the quality incentive programs in traditional Medicare. So MedPAC says that in 2025, about 69% of Medicare Advantage enrollees are in plans that get a quality bonus. And those bonus payments add up to about $15 billion on top of program spending, or about 3%. KFF, has done lots of good work on this as well. And they estimated that in 2024, the quality bonus payments averaged about $361 per enrollee. Now, these quality bonuses are risk adjusted. So the previous discussion we had with David and Neil and about coding intensity and incentives for adding codes in Medicare Advantage are all relevant here as well for these payments. The second way star ratings are used is in setting rebate amounts. Remember that most plans are bidding below their benchmark, and the MA rebate is a % of the difference between the benchmark and the bid. And plans with higher star ratings get to use a larger percentage rebate, as shown in the slide there. So plans can use this amount for supplemental benefits like lower premiums and cost sharing, a lower maximum out-of-pocket amount, extra benefits like dental, vision, hearing coverage that traditional Medicare doesn't cover. And those sorts of supplemental benefits help attract market share for the plan sponsors. So of course, they're very important. So to summarize, the financial importance of the star rating systems is really high. It directly affects plan payments as well as the resources available for supplemental benefits. Next slide, please. So are the star ratings effective? Remember, one of the uses is to help beneficiaries make informed choices among their plan options. MedPAC and others have said that the star rating system is flawed and doesn't really provide a reliable basis for comparing among plans. And the key reason for this is that the stars are measured at the contract level. So for some MA organizations, one contract can actually include many plans, sometimes dozens of plans. Sometimes they're scattered geographically. And so it's not necessarily measuring the quality of services at the local market level for a particular beneficiary. So it may not be so effective in helping to choose among plan options. In addition to this, analysts have found that unfortunately beneficiaries aren't really using the stars as a primary factor when they're making their decisions. There are other reasons that stars have been criticized, other grounds. I'm just going to hit on a few here. They've been criticized, the system's been criticized as including too many measures. There have been too many plans achieving 4 or more stars, the point for getting a quality bonus. This has been declining in recent years, but it's still a concern. Plans that have higher share of high needs individuals have been less likely to get quality bonus payments than other types of plans, and that's raised questions about the adequacy of adjustment for social risk factors in the STARS system. Some specific component measures of the stars have really tight distributions across plans and at high levels. And so a small difference in scores can lead to a big financial difference, especially when you remember that the stars are rounded to a half a star. And so small difference in the performance on a few measures could mean rounding down to 3.5 versus rounding up to 4.0. So it's quite important. And for that reason, we've seen that some Medicare Advantage organizations have litigated the calculation of their stars because of the financial importance of those. We've seen that happen over the past few years. Another issue is that some Medicare Advantage organizations have merged or expanded low-rated plans into contracts that have higher ratings to improve their star ratings. So maybe getting higher payment for essentially no actual change in plan quality. So this is, of course, a concern. Next slide, please. In the interest of time, I'm going to skip over most of this just to note that CMS continually looks at the star rating system and ways to improve it and proposes methodological changes each year. And even relatively small changes to the system can have pretty important implications for the number of plans that achieve 4 or more stars, and of course, the resulting financial resources that go with it. And just to mention that the Health Equity Index that was proposed by the previous administration has been updated to the Excellent Health Outcomes for All reward. That's very similar. It would go into effect in 2027, star ratings, 2028 payments. But the new administration is considering broadening the scope beyond duals, low-income subsidy, and disabled individuals to potentially include others, such as enrollees who live in rural areas. Next slide, please. So to conclude, the star rating system is a very important component of how MA plans are paid, and reforms to that star system have implications for how well it works, as well as the federal program spending for the Medicare Advantage program. So at MPI's website, Neil told you we have a compendium of Part C and Part D policy proposals, and some of which relate to the star ratings. Some of them appear on this slide. The ones at the top tend to address how well the stars reflect quality. Things such as using a smaller, more focused set of measures or evaluating quality at the local market level. Ones towards the bottom offer larger opportunities for cost containment. For example, potentially even eliminating the quality bonus program altogether, or revising it in a way that makes it budget neutral, as in other quality incentive systems. Of course, every policy change has trade-offs. Things that decrease program spending might also have implications for beneficiaries' access to supplemental benefits, or also changes to the Part B premium that beneficiaries in both traditional Medicare and Medicare Advantage pay. So we encourage you to look at our compendium. It's got a rough assessment of what some of those trade-offs look like, as well as links to the primary documents so you can dive into more detail and take a look. We encourage you. With that, I'll turn it back to Carrie.
So thanks, everyone. I know that was a lot of information, but we have a few minutes left for questions. We have some great ones in the Q&A, and you could add there. Some of them have been answered in the Q&A, but I think that there's also some that it would be great to talk about here. One question was, besides the coding research and data points, has there been any assessment or research based on patient or doctor feedback? What does the research show coming directly from patients or doctors? And Andy, I know you answered that in the feed, but if you or someone from your team wants to take a stab at that one.
Yeah, sure. So the way I interpreted that question, Carrie, is whether there's other signal out there, other sources of information about severity that could be used to capture patient risk and adjust payments. And there's been a number of authorship teams who have looked at this recently. David and I wrote a paper led by a student of ours, Megan Bellarose, that tried to get at this notion of like using patient surveys from the CAHPS and the information about functional status and other quality of life, and to assess the extent to which that could kind of be a proxy for risk that would be less subject to gaming. What we found is kind of like good and bad. Like, there's certainly signal in CAHPS, but with respect to predicting future spending, it was pretty weak. That said, like, we said like, well, what if we took the HCC and score, but then calculated it without chart reviews and health risk assessments and added these patient assessments, there was additional signal there. So I think like, and other thing to keep in mind is that survey was certainly not designed to capture like risk with respect to respect to future spending in Medicare. So, I think that the work that we've done and others suggest that there certainly is signal there, that the surveys would probably need to be, calibrated in a different way to get more signal. I think it's expensive to survey patients and there's other logistical issues. So I don't think it's like a out of the box like solution, but it's something that could perhaps be enhanced in the future.
Yeah, I think just to quickly add to that, when thinking about, some of the other impacts that might occur for patients and providers. So, and this is something Andy also put in the Q&A answers. So on the provider side, I mean, there's been some work, and we've heard anecdotally from providers that these requirements that plans put on sort of gaining these additional codes are like a huge burden on sort of a provider's day. They need to spend a lot of time answering prompts that sort of again get translated into chart reviews and translated into other sort of coding capture. And so this does have impacts on sort of the care delivery setting in that kind of way. And also there are some concerns that most patients don't know what they're being captured. And this, somebody suggested this in the chat, that, should patients be informed about what they're being classified as, most patients wouldn't know what their risk score is. And this has some implications because if a patient has too many chronic conditions and they want to leave Medicare Advantage, they can then be denied Medigap coverage on the basis of pre-existing conditions. And so there are some potential patient impacts of getting diagnosis codes that maybe that patient shouldn't actually be accumulating.
It's a great point. Maybe I'll direct this to Rachel. It's about quality measures. Is there any concern about upcoding of quality measure performance through the chart reviews? Could that inflate their star ratings and their bonuses?
So I see David answered this really nicely. So I'll just summarize what he had to say here. So the measures that are included in the star ratings aren't really risk adjusted in the same sort of way using the HCCs. So there's another approach that is used for risk adjustment. So the chart reviews, increasing risk scores, it's not really a big concern for the stars at this point. David, if you have anything more you want to add there.
No, that's great.
And maybe one last question at the very beginning when we were talking, when Hayden was speaking about how payment works, someone asked, isn't the county fee-for-service benchmark, isn't it risk adjusted? So Andy, I think you answered that, but just to clarify that.
Yes, it is. And so this is based on measure risk in the traditional Medicare population. And so basically these benchmarks are set based, determined on the kind of national projection of spending and then the relative county risk adjusted spending. So if in a certain county, if the beneficiary risk adjusted spending is greater than national average, they'll have higher benchmark.
Yeah.
So, this is a situation where you're in traditional Medicare, you don't have the same incentives to code. And, so I think there is risk adjustment there. I think we're still somewhat concerned that it doesn't fully capture risk in certain areas and might lead to distortions in Medicare Advantage payment, but certainly mechanistically there is risk adjustment.
Yep. All right. Well, I see that we are at time, and I want to thank everyone for spending your lunch hour talking about Medicare Advantage cost containment. There are the websites for Medicare Policy Initiative and the website for CAHPR that are up on the screen now. And I know our colleagues at Brown would agree that we'd really welcome you to reach out anytime. Our contact information is on the website to discuss more in depth any of the cost containment or policy options that we covered today. So really, thank you for your time.